Okay, I think we're live. Great, let's get started. Welcome everybody to a new Bytes of Innovation webinar. Bytes of Innovation is powered by Segmed, which is a company that provides medical imaging data to researchers. Bytes of Innovation is co-moderated by Aline, who is the Vice President of Clinical Insights and Real-World Evidence, and by myself, I'm co-founder and Chief Scientific Officer at Segmed, and my name is Willemink. At Bytes of Innovation, we invite key opinion leaders to talk about the future of healthcare. The key opinion leader typically gives a presentation and then we'll have time for questions. In this case, we'll do a short presentation, and then we'll have sort of a fireside chat. So all participants, make sure to put your questions in the chat box so that we can discuss these questions after the presentation of the KOL. Today, I am proud to announce that we have Dr. Tim Stick here today. Dr. Tim Stick is a leading expert in medical physics and imaging science. He's a professor of radiology at the University of Wisconsin in Madison, and he specializes in everything CT, from reconstruction algorithms to technologist workflows. Tim and his team have developed many protocols which have been shipped to more than 3,500 sites around the globe. He's an author of 80 papers, 3 book chapters, 5 patents, and he also wrote the book, The CT Handbook, Optimizing Protocols for Today's Future-Rich Scanners. He's a consultant to multiple companies, and actually in 2023, he founded his own company, RadUnity. RadUnity, we'll hear more about this, of course, during the presentation, but just in general, provides solutions for harmonizing medical imaging. Most importantly, though, Tim is an avid runner, and he won the most prestigious race ever, the RSNA 5K Fun Run. He didn't win it once, he didn't win it twice, he actually won it 3 times. So I'm very excited that at RSNA again, we hope to race together, and Tim is definitely going to be faster than me, and probably faster than anybody on the Segmed team. But we're very excited to have you here, Tim. The floor is yours.
Well, thanks, Martin, for that introduction, and thanks, Aline and Martin, for hosting me here today. I think just like there's a lot of variation in medical imaging, there's a lot of variation in my running times lately, so I'm not sure I'll be able to quadruple Pete at the RSNA 5K, but it'll be fun. I wish it wasn't so early. But thanks for that introduction. I have some slides, and I'm going to switch to those now. So I wear a few hats. Yeah, one of them, like Martin said in the intro, I'm a professor at the University of Wisconsin-Madison. We have a photon counting CT scanner in our lab from GE Healthcare, but then my other hat I wear there is doing all of our clinical protocol optimization. And a lot of the struggles that I dealt with as a clinical CT technical expert there kind of motivated me to come up with the concept behind RadUnity, and I'll be talking about those problems and the solution that we came up with at RadUnity today. So what we do at RadUnity is we do data harmonization for medical imaging. So, I started at the end, sorry. So the problem we're trying to solve is diagnostics that we can't trust. And the issue here really is that medical imaging varies greatly across scanners. And I believe, and hopefully by the end of this, you'll believe too, that can negatively impact patient care. All right, so let's look at reality today. So like most of us aren't just going to like one place in our city or in the region we live and getting all of our healthcare, unfortunately. We're probably going to get, in this case, CT scans or imaging services at multiple different centers. And even within one of those centers, any sort of large or even small hospital usually has 2 or more CT scanners or imaging modality units. Basically, anything I'll say today, I'm going to talk about CT, but it would hold for magnetic resonance imaging, nuclear medicine, you name it. So we got the same patient, they're receiving care, and they're getting scanned on multiple different CT scanners. That is going to inherently cause the data that comes off those CT scanners to be different when it comes to the physicians who are interpreting those studies. So here's an example of what I mean, an unfortunate example. This is the exact same patient scanned on the same day, and we've reconstructed those images 2 different ways that are really common in the clinic. And there's a little lung nodule here that I'm pointing out, and in one case it measures 7.2 millimeters, in another case 4.1. Now the size of the nodule is really key for how the physicians are going to write that up in the report and what kind of actions that might be taken downstream from that imaging exam. And in this case, we have multiple millimeters error just introduced by these inconsistencies between the two scanners. The 4.1 is probably representative of the ground truth, but a lot of times the way images are made, we can get that kind of fattening up or elongation of the nodule size like we see on the left. Furthermore, and this one's a little harder to understand, so I'll spend another slide on it too, but I want to introduce the concept here, and that is you might go to two different hospitals and get the exact same study. Let's say in the examples I'm showing on the far right here, like a rule out pulmonary embolism, or we call it a CTPA, a computed tomography pulmonary angiography. They might scan it on the scanner the exact same way. They do one CT scan of your chest and they administer a contrast agent. But then the images that get made from that one scan, they can be totally different to that go to the radiologist. So let's say one site, they might actually make 1, 2, 3, 4, 5, 6 different kind of views or volumes or flavors, if you will, of that same data set. And then another site might only make 3 of those views or flavors. Kind of analogous to like if you snap a photo like on your cell phone and then you like share it with a friend, but you apply some sort of like filter to it to make it like a cartoon or make it black and white, etc. We do that in healthcare to try to bring out certain image details to make the radiologist's job easier. But we do that variable across all the different scanners in healthcare institutions today, and that can be a big problem. So kind of talk more about that here. So like, I'm just going to give another example that doesn't have to do with pictures. I think one that hopefully some of us can relate to. Let's say you're an investor and you're looking at a portfolio of companies that you've invested money in. Right now, they have to waste time translating numbers instead of making insights on a company's health. So like they're going to go out to their companies and they're going to want some of these key stats, like what's your burn rate, what's your runway, pipeline, etc. Every company is going to kind of give that information back to them, but in a slightly different way. So now you're the portfolio manager. Let's say you've got 12 companies in your portfolio. You ask for the same piece of information. You get 12 different answers, and you got to invest some mind space figuring out exactly, okay, they included an extra month here. I need to modify that number this way, etc., before I can compare apples to apples. That is completely analogous to a physician that's interpreting medical images, except instead of like 12 portfolio companies maybe that they're responsible for, those radiologist physicians, they might be reading like 12 studies in the morning and 12 studies in the evening, and they're debating hundreds of studies during the week. So there's a constant kind of mental like mind space waste that they have to expend translating the information in these images before they're actually focusing on the patient, focusing on actually making a diagnosis. So that's kind of like what I'm showing here. They've got this different variable input. They don't want that. And at the end of the day, there might be just a small set of things they actually need to see, and they're wasting time finding that. So what we do in my day job is we try to solve this problem. What I'm showing on this slide, and I'll talk about the 2 different ways to solve it, is how RadUnity solves it. So reality today for sites that don't have like me as their CT physicist, let's say, on staff, is that those sites are making completely different sets of images with different names and different numbers across the different scanners in their CT fleet. So here, don't get stuck on like what vendor is here and if there's better vendor or not. No, that's not the point I'm trying to make. The point I'm trying to make is that you're trying to do the same thing on 3 scanners within one hospital. Most sites today are going to be generating 3 completely different sets of images, even if we're just trying to do, again, like an example, a CT pulmonary embolism, like I'm showing here. Different names, different numbers of images. All right, so in my day job, what I try to do is solve this problem by going and manually programming each one of those pieces of equipment so that they produce the same output. That's a challenge, though, because I have a team of 4 technologists plus myself. At times, we're hiring undergrads to help us. Big team, we're spending a lot of money. I think our FTE budget is like over $1 million. And we go and we sit down at those scanners and we program. There are hundreds of thousands of parameters that we have to worry about when we're doing that, because we've got hundreds of protocols on each scanner. All right, so it's kind of an intractable problem that only sites like, say, some academic hospital like I work at, we can really afford to do that. So RadUnity comes in and says, okay, forget that. We're not going to try to solve this problem by hard coding in all of that uniformity on the modality units. Instead, we're gonna accept that non-uniformity. We're going to ingest all of that, and then out of that chaos, we're going to find the key image series that the radiologist wanted. And if we can't find those, we're going to manipulate the image data that's there, excuse me, to produce those image volumes. And that's what I'm showing here on the far right. Some downstream things of why this is important. So like I already talked about, what we're doing then is we're making sure the quantitative information for like size measurements maintains constant across these different scanners. We're also trying to reduce that mental brain drain. So the physician who's looking at this always sees the same thing every time. They're not trying to like find what they need. They know it's going to be there. They know it's going to be called the same thing. And then I think in the growing world of AI applications where some of these AI algorithms and companies are very advanced in how they ingest data, others not so much. So those in the category of not so much, we've got vendors who like expect that things are named the same. Okay? They expect that they're always going to be fed a certain slice thickness and slice interval. These are terminology we use to define just how thick the individual images are of patient anatomy. But in reality, like that's rarely the case. If you've got a bunch of scanners you're managing, those vendors that expect the same slice thicknesses and names, they're going to have a lot of issues with not being able to process data in a robust way. So those are some of the things that I think are a challenge when we have data non-uniformity. And I think that's the last slide I want to show right now. And I just love to kind of get into this with two experts like Martin and Aline and see what I can learn from you guys and maybe explain better. Yeah, thanks.
Thanks so much, Tim, for this presentation. This is all super relevant to, of course, for patient care, as well as for the work that we do at Segmed, compiling data sets for research. So what are the biggest drivers of this data variation across sites? Is it because of the hardware or the protocols design or the reconstruction algorithms, or maybe related to the operator technique? It's probably all of that, but what would you say are the main drivers?
Yeah, excellent question. When I first started down this road, I was wrong. I had the idea that this was caused by like, physicians wanting their way and like them coming in and like calling the scanner being like, I want it this way, and like they were the problem. But that might be true at some sites where like that's the biggest source of variation. There are sites that like depending on what physician's in the reading room, they try to do it differently, tailoring to that person. But I don't really think that's the case anymore. I think we're really like there's multifaceted, but at the end of the day, the most important thing is just that we're doing a lot of really like different things. So we have hundreds of different things the CT scanner needs to do, from like a routine non-contrast head to some really advanced like gated chest followed by the scan of your whole abdomen pelvis, to some really easy like ankle type scan. So like we're doing a lot. And then to program each one of those, we have dozens and dozens of things we can change. And they're all different for different CT scanners. So we've just got this huge list of like custom things we got to do. And we've got this huge amount of freedom in how we can do it. And it's not fair like to blame physicians or blame technologists or blame the apps specialists from the vendor that they're the ones driving it. I think we're just it's inherent to so many choices. Yeah, that's what I've come to realize.
Yeah, for sure. Well, I'm an ophthalmologist by training, and things are much simpler. In the ophthalmic space, we do not have that many options. So my next question is about the patient variability. How do you think patient, for instance, body composition or pathology, or maybe motion, position, how does patient factors cause variability?
Yeah, excellent question. So for sure, if I have a fleet of scanners, let's say in my ideal world where they're all the exact same scanner model and they're all running the exact same protocol, And then I bring a wide like range of body habitus from like 90-year-old, 90-pound, patient to football player size person, right? We're gonna have some variability there. Most modern imaging equipment for CT is going to adapt to different body habitus. And in that adaptation, sometimes it's good and sometimes it's bad. A bad example would be if they change the tube potential or beam energy. I'm not going to go into all the physics. We can, but like basically the values, the quantitative values in the image will change, and that'll be by design, per the protocol, and that's just how the machine operates. We might also program that scanner to allow more like image noise in the larger patients, and that means that as a function of body habitus, I have a change in my image quality. So like if you're developing an AI algorithm or something like that, and it can only, if it's doing some aortic segmentation and it can only handle this much noise, and now I've got a protocol that's fine. We're always operating under that, except if my BMI is over 35 or something like that, that can cause a problem there. So for sure, we're going to have some inherent variability due to body habitus, and that's like literally programmed into how every single vendor's, we call it automatic exposure control. It's just a way to adapt to patient size operates. Other examples of that, though, can be things that like a place, like a fancy academic place like us, we got too much time on our hands. We might make different, we make different flavors of a protocol depending on how the patient presents. So if the patient has metal, we're going to introduce a little variability into that protocol to try to better image that patient. We might scan them a little differently. For example, if they've got dental amalgam, we might have the patient move their head and scan so we don't have streak artifacts going at the base of the brain. Or we might tilt the scanner and rescan them. So that means the radiologist on PACS is where the physicians interpret images. They're going to have some extra series there that's non-uniformity, but that's kind of built in to get quality. I could go on, but yeah, I think you're exactly right. There's right now a best practice CT is going to have variability due to body habitus or due to different patients for sure.
Yeah, that totally makes sense, Tim. And this is actually a very interesting topic. I think, as you know, in my previous life, I did a lot of research on these kind of things as well. Actually, one project we did was we had multiple ex vivo human hearts that we scanned under CT scanners from 4 different vendors, and we just used the vendor recommended protocols. And then we looked at, hey, if these were actually patients, we did a simulation study, how many patients would be reclassified if we would do calcium scoring, Agatston scoring? And we found that 6% of patients actually would get a different risk classification for cardiovascular risk if they would be scanned on a different scanner, up to 6%. So it was kind of interesting finding. And the example that you showed earlier was also on lung nodule measurements, right? So I feel like it makes a lot of sense that this data inhomogeneity results in inaccurate measurements. But what actually is the effect on the diagnostics? Like for a radiologist in the daily life, how important is it to work with images that have been harmonized by RadUnity versus just using whatever they're using now?
Yeah, so I can't answer that question with like a study, let's say. I wish, in the future, I think that's something that I'm very interested in doing. I think we will be able to shortly to answer that question more and more with AI-based CADX and CADE because you can more easily look at performance of those algorithms. It's like an awesome way to do it, like a quasi-reader study. And in my opinion, I'm not comparing AI to a radiologist. Don't want to get in trouble here, but I think that is one thing you can look at is performance of those kinds of tools with variability by scanner, and there's definitely changes there that I've seen. But yeah, that's a harder problem to really get at it because like radiologists today are just so used to a lot of variation that I don't think commonly they are blaming it for misdiagnosis or yeah. I think the throughput angle and that mind space angle though, there's definitely data out there that if you're fatigued and things like you're gonna miss more stuff like that's no question, right? So you want your CT read like right after the rad, drink some coffee in the morning, and they weren't on the night shift, right? No, but I think like now that we have so much increase in CT volumes, like this is pretty much true for like most of the world. Like my site's looking at putting in more rooms to do CT, extending CT hours. We have like 6-something digit growth. It's just crazy. So the rads themselves are also getting more RVUs out there, like reading more studies, things we can do to try to lessen that mental fatigue for, like I said in my talk, like these tasks that are just having nothing to do with making any diagnosis. They're just kind of like paperwork almost type tasks that physician needs to do to get things in order before they can practice medicine. That impact will be like harder to quantify, but when I talk to people that are running some of those like radiologist groups out there, like those private equity type, they're trying to do whatever they can to increase the throughput from their ads and keep their employees happy. So like they can make their employee more efficient and happier because they're spending less time on these like menial tasks. I think that's like definitely a win.
Yeah, actually, last week we had Pranav Rajpurkar from Harvard and A to Z Radiology on Bytes of Innovation. And one of the things that came out there was, hey, probably AI should be focusing on those kind of tasks where you're doing measurements, right? And so that the radiologist can actually focus on the diagnostics. And I can imagine if you harmonize those images, then AI is just simply going to perform better. And the variability will decrease. Talking about variability, you showed that example of the lung nodule measurement. I know that if you ask 2 radiologists or 3 or 4 radiologists to measure the same nodule on the same scan, you'll get some variability. How much of this is caused by inter-observer variability, or is there actually a true effect based on the non-harmonization of data?
Yeah, for sure, both are real. And I think I could say that with confidence from a lot more work that's been done in inner user studies in radiation oncology with contouring. I think that is kind of like the elephant in the room. And sometimes for those discussions there, because like 2 different radiation oncologists will like contour things like completely differently on the same data set. But then if you also feed them like different enhanced data sets or contrast enhanced or so forth, they'll like see the margins of a tumor better, and that will cause their contouring to change. So that's what I mean by I think both then are also true for radiologists, that they'll measure things differently, observer to observer, and then across different acquisition parameters, right? Because their whole like eye brain system is keying in on like little subtle changes in contrast, and then like those are the things that change when you change CT vendor or change reconstruction settings. So like of course it's gonna cause their measurements to change. So yeah.
My turn. Sorry, Martin. So let's talk a bit, Tim, about harmonization and standardization. So here at Segmed, we use RadLex playbook for protocol naming convention. And now we are starting to look into series names conventions. So how do you think the naming part is important across sites and acquisitions for research as well as maybe for patient care?
Yeah, the series names that's a huge challenge. I think it's important because if you're a radiologist at a hospital like mine, I did this once and I just spent like a few hours looking at radiologist reports, and like I think it was like literally I think I found like 1 or 2 that didn't mention a prior or talk about follow-up imaging. Right. So I guess what I'm trying to say is like the vast majority what the radiologists I work with do is compare the current study to a prior and talk about the need for some sort of follow-up, whether it's another modality or another CT scan or something like that. So we know when they're opening up study, they're going to be looking at those prior images. So then like anything we can do to make it easier, to say like, okay, this is a multi-phase study I have today. If I'm looking for a change from the prior, like it probably doesn't make sense to compare like the arterial phase with like the portal venous phase on the prior, unless that's like all I had, right? So making a uniformity in those series names, I think makes those longitudinal tasks like super, it's going to make that super easier, way easier. I think like the series name test, that's actually something like I came up with my team like years ago. We had a convention at the University of Wisconsin. I know RSNA. I've been a little bad about always making all the committee meetings. I haven't gone in a while, but they have a committee. I'm actually not sure where it's at about redefining like a standardized like Radlex playbook version for series names. You guys probably know more about that, the latest than me. I haven't been able to make those lately, but they're trying to come up with like a community-wide consensus. I struggled with my team for a while. We made ours, I don't know, probably like almost 10 years ago now, because we realized we needed a convention for that. And it's really not that easy because you're either going to make your series names like a sentence and then it's descriptive, but no one wants to read it, or you're going to make them crazy short and then it's really cryptic and you're going to need lots of training to like, decipher what's going on there. And then in between, it's just kind of a compromise and that doesn't make sense. So like at our home institution, we do have series names that are kind of more on the cryptic side because no one wants to read a, sentence. But yeah, that's a huge challenge. And I think like that's one place where like AI is like the obvious way to do this better because what we're really doing when we're doing series names is we're saying like, okay, what contrast phase was this, right? And we want to make sure the series name has that in it. And like that's AI can do that pretty well. Maybe what is this, a soft tissue reconstruction? Is this a lung reconstruction? Again, like, sure, I have 3 different CT scanners. We might use 3 different reconstruction kernels or algorithms. We can get into that if you want to, but like, the different vendors call it different things, but like AI could easily know like, oh, this image is intent. It's a portal venous phase, but it's like got some of the lungs in there and it's reconstructed with like a lung appropriate window. So the AI could like easily figure that out. So I guess where I'm going is we don't always have to rely on like super good names. If you've got a PACS that's kind of got some of that smartness embedded in it and it can hang those relevant priors up, I think, that for sure will be the future. And then this need for like the naming on the operator side or the protocol team side won't really be that big of a deal. Maybe I'll also say like then obviously like so like in my company like yeah of course we want to look into and we have some ways to help the customer help the user do that where we'll like pass them through some layers where we can kind of auto assign some of those names so they don't have to worry about it. And that's important because a lot of sites don't have 300 protocols. They have more of an elephant gun approach. And when you have an elephant gun, what I mean by that is maybe I have 1 or 2 like protocols that I span maybe 20 indications of the abdomen for, whereas Wisconsin, maybe we have like 6 or 7 different protocols. So when you only have like a few protocols, you're going to be using them in different ways with potentially different timing delays and so forth, and you might need to make those changes to series description on the fly. Like no one's really doing that. So you really could benefit from some sort of a layer that does a normalization before those images hit the PACS. And I think that's what we're seeing today. There are companies out there that do that already, just the series name. And like a company like my own that'll like help a user do that.
Yeah, makes sense. Yeah, and that's a very interesting discussion indeed. I think if we had some sort of consensus or mapping now with LLM, we could try to apply. At Segmed, we have data from hundreds of sites across the US, so it would be a good experiment to apply the harmonization to the series names. So I want to make sure we cover AI, and there is a question in the chat from Jessica. So Jessica's asking, based on your experience, both at UW and with RadUnity, could you highlight if there are specific imaging modalities or clinical use cases where data variation is particularly problematic for AI?
Where data variation is particularly problematic. Okay, yeah, I can speak. I won't mention names of the AI vendors, but I know we trialed one that it did some denoising for CT and like it was a little strange to me. It processed the images differently based on like the window width and level that the images were at. And it would like put them into different types of classifications and process them differently. And it was very strange behavior. It caused like some problems with us when we were trying to implement that. That was relatively recently. I don't know if that vendor like moved away from that. I told them they should, but like that was just one example where like, you wouldn't think something like that would cause a downstream AI to have a problem, but there you go. It did not like that, and it had some problems. Another maybe less silly, but like that wasn't important. Like that caused a problem. Like here's another example though. If we've got an AI algorithm that's supposed to run, like let's say every time it sees certain types of body, like anatomical regions, but it has like a computational like step to like determine if those regions are present. And because there's a computational step, we don't turn it on for like every orderable or orderable is like, every type of CT exam that we do, we have like different groups and classification, like heads without contrast, chest without contrast, chest with contrast. So that's what orderable means, level set there. So like, let's say we didn't turn on that like step for some sort of orderable where there was that anatomical region, then the radiologist, and like this happens, like then they're like, hey, why didn't this AI thing run? Like, I actually like this AI thing. Like, it's not running on these cases. And then we got to go back and troubleshoot and be like, oh, there's just like this implementation step because like the metadata that's in the images kept it from some filter from turning on and enabling that AI algorithm to run for that radiologist. So there's some like, you could call that like a issue with configuration, but I don't know. I kind of view that more as like a data normalization or variation problem because like at the end of the day, like we should have the right kind of metadata that like whenever we have some certain anatomy that's represented in the DICOM or some other means, and then the AI can key off of that without some computationally intensive like algorithm to do like organ segmentation or So those are I think two two relevant examples that have come up and like cause us issues where patients aren't getting the kind of images the radiologists want to see or the kind of AI augmentation to their workflow that the radiologist wants to see.
Yeah, very cool. And what about the barriers? What do you think are the main barriers for widespread standardization? Do you think are mainly economical, technical, or just organizational?
Yeah, the main barrier. So everyone, I think, whether they know it or not, like they would benefit from like a normalization, right? But I think they're gonna benefit in different ways and then they put different values on it. So when I talk with folks, I think that's one challenge is like making people realize like what life could be like if they didn't have that variation. And if you're talking like, let's say if I'm RadUnity talking to like an AI vendor, like they're going to be spending a lot of money on trying to make robust ingestion algorithms. And like a cheaper solution would be like normalizing the data before it hits those ingestion algorithms. So like there, maybe that's the kind of approach you take. If you're going to radiologists that are just private practice and just really busy, I think they're going to appreciate like the hurdle might be less so because you just say like, hey, like if you're this more efficient, it takes you this many seconds or minutes less to organize a study before you begin interpreting it. Then you're ready to go. Whereas a hurdle for them, if you lead with, hey, like your measurements are going to be more accurate, if the data's not there or like the like incentive is not there to care about that as much, then like they're not that's a hurdle for them. And then on the flip side, if like you don't have the robust data for some academic place that you're really making a game changer for measurements, like they might not care about the efficiency gain as much. They're not like chasing RVUs like some other folks. So I don't know. I feel like the answer to that question was more like a business one than like a scientific or clinical one, but those are like the realities, I guess, that I see. The the more clinical one would probably just be like there's always going to be some important radiologists at a place or technologists that like what they're doing. And the change management involved to get uniformity the manual way, holy cow, that is very, very, very difficult. I know this because we've got like a decade of experience with like no RadUnity hat, just like my UW hat on. We've been shipping these protocols through a vendor, a CT vendor partner around the world. We go in there and try to get uniformity to them by, reprogramming their CT scanner We don't manually do it. We can give them a disk, and it's got uniform protocols. But then the second you change a little piece of a technologist workflow or a little way an image looks that a radiologist has, like that often is met with a lot of resistance. So the manual way to get variation, I think there's a really we cannot underestimate that change management piece of that. That's why I do like one value prop is when you have an automated like an AI or like what RadUnity does normalization layer, you can actually give individual physicians whatever they want to look however they want, and they can interpret that. But then when their colleague opens it, it can look however that person wants. So in that way, like you can kind of kill two birds with one stone. That like you could have a site that like let's say 80% of the physicians want it one way and they have uniformity and that's great. But then if one radiologist wants it a different way, you could actually give them that and make the priors, let's say, look like that too, and get some of these benefits I talked about, but also allow like individual like specific variation. Yeah.
That's very interesting. I actually didn't realize that, Tim, that you can provide that individualized those individualized preferences to each radiologist.
We don't have
'cause
that like product well, we have it like we can do that. It's not like in our current product, but that's on our like we've shown that that's like it's really not that hard to do. I mean, you could do it on the current like what we do today by just setting up a different make us two different profiles and then you just run it that other way. But you need like a link to the packs, and then once you know what radiologist is logged in, it's not that hard to just see what that user specific profile is. We just haven't built that yet, but it's that's I think probably could be the future for some sites to really adopt some of these things. Yeah.
Yeah, that makes total sense because there's as much variability in radiologists as there is in reconstruction and acquisition settings, right?
Yeah.
So
Yeah.
that would actually, I feel like, be a big solution. My next question for you, Tim, is you showed the slide with, like you have the images that are totally not harmonized, then you have RadUnity, and all of a sudden it's beautifully harmonized. What is it that RadUnity does? This slide here, let me pull it up actually. There we go. What is it in 2 sentences or 3 sentences what RadUnity does to harmonize these images?
We find the highest information containing image and we reformat it to make all the other ones. That would be my high level. So every scanner can make a pretty image, and that's like say thin slice and high resolution, and then we dumb those down constantly so that our human visual system can see things easier. So what RadUnity does, we get that, so we call it a source image or high image content volume, and then we use that one and just make reformats of it and fill out the profile that was ordered, say, or predefined for that indication. So that's like the secret sauce. There's no like fancy black magic AI stuff. It's, algorithms have been around for decades to do simple image reformatting. They take milliseconds to do on a volume, and the secret sauce maybe in the workflow on like how you actually do that, but that's like the back end like technical piece that's how it works.
Yeah, interesting. One other question I have, and I see there's another question from the audience, which I will do after this, but there are new modalities, new technology is coming out regularly, especially now with, for example, in CT photon counting detector, CT, which results in completely different spatial resolution images. There's even images with color that we didn't have before, if you look at material decomposition and things like that. How do you handle things that are changing, like drift in the data within RadUnity? Like how are you, for every new technology, you're going to have to adjust your model?
Yeah, we would let the user have the freedom where if they have a scanner that's just head and shoulders above other ones, that one has a special profile. We're not going to ever like take away some of those advantages that you'd get on a photon counting scanner and dumb it down to make it look like the other ones. Like that would be a step backward, and we definitely, the technology would not like force something like that to happen. Yeah, it's a little bit of a catch-22 with vendors. Like if I look back when I started my career, like there was like scanners then that like I would go get a scan on today. Like from the scanners of like when did I start? Like around 2008 or whatever. Those scanners were like fine. There's been a lot of little nickel and dime improvements that it would make it kind of like a night and day, but like for most of the orderables and types of CPT codes that we have, like routine heads, routine chest, routine belly, PE, you name like all that kind of stuff, elbow scan, like you would be fine on those scanners. So um so the catch-22 is like, okay, so when a new scanner comes out with a new technology, like what do you do with that? Do we try to like take it away and normalize it back, or do we try to like let it remain? So that is like a little bit of a conundrum, but like our technology, say in particular, would like let the user kind of decide how they wanted to do that. If there's a special extra map on a spectral scanner, leave it. Like that's extra information. The rest of the images, though, if there's really no big deal why they can't be like looking like the rest of the fleet, make them look like the rest of the fleet. And you get the best of both worlds there, I think.
Yeah, that makes sense. Okay, we only have 2 more minutes. I'll do this audience question and then I'll close it out. So this is a question from Domenico. Can you share examples of situations where small differences, say in CT kernel or slice thickness, have led to major discrepancies in interpretation and maybe in measurements as well?
Yeah, we have a vendor I won't name that does like FFR stuff, and like they'll fail us on the FFR because we don't have high enough resolution. We make a tiny tweak to the reconstruction kernel, and then they say it passes. Okay, so like we have two kernels that are like to use technical jargon, like a line pair away from each other. It's very close, and you reprocess it with this other one, and then somehow magically this computational fluid dynamics thing is working. So there are examples like that, or same thing with like coronary plaques or something like that. You change the kernel a little bit, and that might bump, like we were talking about earlier, the physician, their inner reader confidence to call it something else or confirm that they were a little suspect that wasn't that included, and now they're certain. So I see that a lot, like yeah, I think that's pretty common, that you can see those kind of little changes make big impacts with those kind of algorithms.
Yeah. Yeah, I feel like these little changes are actually underestimated very often. So I think it's important, the topic that we're discussing here. But we are actually at the end of the webinar. So I would really like to thank you, Tim, for an amazing presentation, a great discussion. I would like to thank you, Aline, for co-moderating with me again this Bytes of Innovation session. And also I would like to thank the audience for your questions and for being with us on this presentation. We had a great Bytes of Innovation season in 2025. We had Matt Lundgren from Microsoft. We had Dr. Ing Ho from board director at Segmed. We had Dr. Pranav Rajpurkar from Harvard and A2Z Radiology. And today we had Dr. Tim Stick from UW Medicine and RadUnity. So really great. We're now going to go full steam ahead to RSNA. Have the holidays after that. So we won't have any Bytes of Innovation episodes this year, but in 2026 we'll have a new season with really exciting key opinion leaders there as well. So I hope to see you all at RSNA. Make sure to attend the Segmed booth 5147 at the AI Showcase area. And Tim, if you want to do a shout out for RadUnity at RSNA, this is your moment.
I will be there, but we don't have a
You don't have a booth.
Sorry.
Okay. Make sure to follow Tim Stick there as well. Yeah, thanks everybody, and I hope to see you next year.
Thanks.